Hello and welcome. Thank you so much for joining us for what will be a very comprehensive webcast as we dive into understanding the global insights into metastatic breast cancer. I'm Vicky Durst and I'll be your host for today, but before I introduce you to our guests, I would like to begin by acknowledging the traditional custodians of country throughout Australia and their connections to land, sea and community. We pay our respect to their elders past and present and extend that respect to all Aboriginal and Torres Strait Islander people today. I would also like to pay my respect to all of you joining us from around the country. We have over 550 registrations for today's event, spanning states and territories, but also international guests as well. I wanted to thank you for sending in your questions prior, and also particularly acknowledge Breast Cancer Network Australia's lived experience reference group of those living with metastatic breast cancer, because without your support, we couldn't have put on this program. We will be inviting questions for today's webcast. However, please note that these questions have informed, or the questions that we've done through the pre-event survey have really informed today's program, but please use that live Q&A tab and we'll do our very best to get through. As we discuss the latest emerging new treatments and the evolution of treating metastatic breast cancer, we do have this incredible opportunity today to draw from the expertise of Dr. Hope Rugo through this webcast, alongside Katie Thorpe, a young woman living with metastatic breast cancer. Dr. Hope Rugo is going to outline the new class of drugs and what we need to know coming down the pipeline from overseas. So without further delay, I would like to get straight into introducing you to Dr. Hope Rugo, who is a Professor of Medicine in the Division of Haematology Oncology at the University of California. She is a Director of Breast Oncology and Clinical Trials Education at UCSF's Helen Diller Family Comprehensive Cancer Centre. She's an internationally recognised expert in breast cancer. Her research interests include novel therapies for advanced breast cancer, immune modulation to restore chemotherapy sensitivity, evaluation of circulating DNA as a marker of response, and resistance to therapy, neoadjuvant therapy, and safety supportive care. She is a principal investigator of multiple clinical trials and has published widely in medical journals. Thank you, Hope, for taking the time to talk to our network, and welcome all the way from the United States. So
thank you for having me.
It's incredible. So I would also like to introduce Katie Thorpe, who has joined us this morning, got on a plane from New South Wales, but also want to say thank you. You are a member of our Breast Cancer Network Lived Experience Reference Group. Katie is also a marketing and design professional, and Katie tells us that she's a dog mum and a young woman's health advocate, diagnosed with stage 2 ER/PR positive breast cancer in 2018. She underwent 3 surgeries, 6 months of chemo and 23 rounds of radiation. Despite completing her initial treatment in October 2019, she received a stage 4 metastatic diagnosis in May 2020 after the cancer had spread to her bones. Celebrating 4 years of stability on her first line of treatment, as she describes, Katie continues to work in health advocacy, stay active with regular gym sessions, and support women's health through various campaigns. So thank you so much, Katie, for joining us. I'm going to jump straight in first, though, to you, Hope, and ask the question. And I know this is something close to you as well, Katie, being on a CDK inhibitor. But with precision and personalised medicine being the way of the future, Hope, and we're hearing that CDK inhibitors, and we're being told, have become a game changer in the management of metastatic breast cancer due to their ability to slow disease progression. Why are these new class of drugs receiving so much attention worldwide?
Well, I think it's a great question. I mean, hormone receptor positive breast cancer is the most common subset of the most common cancer diagnosed in women worldwide. So it's really important for us to understand how to optimally treat hormone receptor positive disease. But it's important to keep in mind that hormone receptor positive, and I'm meaning HER2 negative, breast cancer is very heterogeneous. And some of the cancers are very slow growing. with low cell turnover, and others cancers are much faster growing and more resistant up front. And it's really hard for us to understand the differences between those cancers, and we're working really hard looking at different mutation profiles, proteins, and now taking the next step of putting together all of these different factors to try and really understand the heterogeneity or differences between hormone receptor positive breast cancer. And so we've always been thinking, okay, the mainstay of treating hormone receptor positive breast cancer is hormone therapy. We understand now that there are subsets and situations where chemotherapy is also indicated, but we're still trying to separate out when chemotherapy is working because it's chemotherapy killing rapidly dividing cells, and when chemotherapy is working because it's having toxic effects to the ovaries, which you could do through other means. So maybe a little less toxic, but still suppressing the ovaries. So that's been sort of our focus in understanding hormone receptor positive breast cancer in early stage disease, which cancer needs chemotherapy or not, and in metastatic disease, how we sequence therapies. So then we were thinking, okay, tamoxifen is the mainstay of treatment, but you could treat patients with these new class of hormone agents 20 years ago, aromatase inhibitors. And we discovered through randomized trials called SOFT and TEX that for women who were very young, and particularly for women who had more cancer, that suppressing the ovarian production of estrogen and giving this new class of drugs, aromatase inhibitors, was better. So that was our next step, and so that also became the standard first treatment in patients who had metastatic breast cancer. And aromatase inhibitors have their issues, but this was really our standard of care. So then the question was, could we improve this further? And actually the first thing we did was to target a common mutation called PI3 kinase, or PIK3CA, and it's about 30 to 40% of breast cancers. We moved on now to understand their estrogen receptor mutations using different novel hormone therapies. But alongside all of that work, and it turned out that targeting PIK3CA effective has a lot of side effects.
Okay.
So, and it was really hard to look at things, and we looked at these trials and we said, we can't see survival benefits. We're never going to see survival benefits in metastatic hormone receptor positive breast cancer. So then one of our colleagues in LA actually took a cyclin-dependent kinase 4/6 inhibitor, blocks an enzyme that makes the cell grow. So the cell divides, it grows. This is called the cell cycle. These were drugs that blocked two enzymes that were part of the cell cycle, 4 and 6. Lots of CDKs, cyclin-dependent kinases. So they took this drug off the shelf that hadn't really been used and found that it worked really, really well in hormone receptor positive breast cancer. So if we go all the way from that to where we are today, we've seen that when we combine these CDK4/6 inhibitors, there are 3 approved drugs, with hormone therapy, any kind of hormone therapy, we can markedly improve response, the duration of response, and in some cases survival. And of course that brought up a huge amount of interest in using these drugs to treat early stage high risk breast cancer, where they've also been shown to improve outcome. And there is already one, abemaciclib, approved for early stage breast cancer in combination with hormone therapy. And of course the success is effectiveness, but it's also been tolerance. Of all the targeted agents we can combine with endocrine therapy, these drugs are the best tolerated, with variations between the 3 drugs. Palbociclib, the best tolerated drug, but the other 2 drugs, we have to really learn to manage the side effects to optimally use these drugs. So, we've come a long way from starting with tamoxifen, still a very active drug, to these combinations, which we believe in higher risk hormone receptor positive breast cancer can reduce the chance of getting metastatic disease, and in metastatic breast cancer markedly improve outcome, which is really fabulous.
And can you explain to the audience the difference between the 3 of what we use for metastatic breast cancer?
So there are 3 cyclin-dependent kinase 4/6 inhibitors, CDK4/6 inhibitors, and actually now research is looking at CDK4 and CDK2 inhibitors separately. CDK4 probably the most promising in breast cancer. So we're moving on. But there are 3 drugs, so palbociclib, ribociclib, and abemaciclib. And palbociclib, interestingly, the study of it has been more fraught with difficulty because probably being the first kid on the block, the studies were a little bit more difficult to do in terms of looking at survival endpoints, a lot of heterogeneity again. For ribociclib and abemaciclib, the studies were done a little bit later. Ribociclib is the one CDK4/6 inhibitor where there's been survival benefits shown across different lines of therapy and different combinations. But abemaciclib also appears to have some of that benefit, certainly in the later line setting. And there, again, I think these trials have really helped us as investigators and providers to understand that clinical trials can be fraught with difficulty. How you design the trial, the number of patients, when you're doing it, what you get after the trial in terms of treatment. I have had 4 patients who started on the first trial with palbociclib who have been on treatment for 11 years. So I know these treatments are very, very effective. In terms of the side effects, palbociclib and ribociclib are given 3 weeks on, 1 week off, and they mainly cause a drop in a subset of the white blood cells called neutrophils. So we're always checking to make sure they've recovered. But they don't increase serious infections. Ribociclib and abemaciclib can cause elevations in liver enzymes, and that has to be monitored very carefully. Ribociclib also can cause a prolongation in part of the EKG. It doesn't happen much, but you can't combine it as safely with tamoxifen because of that. And then abemaciclib causes diarrhea as its primary side effect, and the neutropenia, or low white blood cells, is a lower risk, and managing that diarrhea has become a big issue for the early stage setting to try and understand how to manage it. But dose reductions, dose delays, a lot of understanding of the optimal ways to manage these side effects makes a huge difference. All 3 drugs cause fatigue, some hair loss, so thinning of the hair. It's very variable. You have great hair.
It's a lot thinner than it used to be.
I know, and we've been actually using this old high blood pressure drug called minoxidil in really low doses. Really thickens the hair. No side effects, works really well.
Yeah.
The side effects are mainly that you could grow hair on your face too, but so that depends on how people feel about it and what happens to them. But so fatigue, the hair loss, and then occasionally a mouth sore. We use the steroid mouthwash or steroid dental paste that makes it go away. Very individual. We don't know who gets those or not. So that's sort of the broad spectrum of how those drugs work. For fatigue, dose reductions work the best, I think, overall.
And dose reduction, we're talking about clinicians working with the patient to really look at what's right for them when we talk about dose reduction.
Absolutely. And I think that's so incredibly important, really talking to patients about how this affects their quality of life, their lifestyle, what happens to them, and really giving people the right recommendations, For example, if you're taking abemaciclib, you shouldn't eat a big salad and go out on a long hike away from bathrooms because you might get bad diarrhea. Things like that, monitoring your white blood cell count, when to come in and talk about issues. And these dose reductions and sometimes dose delays, you're not feeling great, take an extra week off. This makes a really big difference. I mean, the name of the game here is we want to optimize the effect against the cancer, but we want to do that and help people to live the best life they possibly can.
Yeah, and I know that, Katie, you've been talking about fatigue in relation to, the medication that you've been on. Can you just talk us through with Hope what that means for you?
Yes, absolutely. And I relate to working with your clinician to find that right dosage, because I had 2 dose reductions before I found that real sweet spot where I could live life fully and manageably. But it is about 3:47 that I usually start to head on that fatigue downhill. So I've had my coffee today. I'll try and stay on. But I think it is such a common side effect within the metastatic community on a lot of these treatments that we're on. Some of us who may have been on treatments such as chemotherapy earlier are used to experiencing very different side effects. How are these new class of treatments coming through differing in terms of the traditional cancer side effects that we may have found 5-10 years ago?
Well, I think that it's a really important question. I will say for the fatigue, there's quite a bit of data that exercise can help, but it doesn't fix things. For that afternoon fatigue, that's a really funny thing because that is a common time, where people feel quite tired late afternoon, which is really, still part of the big day. We do use low doses of methylphenidate which can help a lot, a drug that had been used for children for attention deficit disorder. And we find that that helps a lot of people quite a bit. So that's one thing that we use. In terms of the new drugs and sort of what we were thinking before, it's an interesting thing because we have these drugs that we add to hormone therapy. We have a whole host of new hormone agents. We have one new hormone agent, an oral drug like fulvestrant that's approved in the United States, but only for patients whose tumors have estrogen receptor mutations. And so we're learning a lot about oral drugs and how we balance the side effects of oral drugs against what happens when you move to intravenous therapy. And I think for a lot of patients, in the metastatic setting, moving to IV therapy is really a challenge. People are worried about their access and being attached to an infusion center and the time you spend there. And then also the side effects, because a lot of our drugs are associated with at least some or full hair loss. And the blood count issue is a bigger one for many of these drugs. But I have to say, now that we have antibody drug conjugates as part of our treatment as well, that although those drugs have some chemo-like toxicities because they're delivering chemotherapy in a different way, they're really quite different from what we've seen before with chemotherapy. And again, fatigue is one of the biggest issues that we see along with the other side effects. And there are unique side effects from different, of course, agents that we see, whether that's diarrhea or inflammation in the lung, et cetera. We're looking at these. The new class of oral endocrine therapies seem to be pretty well tolerated, and a little bit of nausea, some flashing lights for some of the drugs, but overall they're really well tolerated, and that's exciting, I think, because we could really, use these drugs more effectively to manage the side effects of getting, fulvestrant is the drug we give after aromatase inhibitors, which have their own set of side effects, but getting a shot in your butt, 2 shots in your butt once a month is not great either, right? So taking an oral medication, we hope will really be the go-to approach in the not too distant future.
Did you want to ask the question around the new class of drugs?
Yes, you did mention the antibody drug conjugates, another form of novel and personalized therapy. Can you tell us why this is novel and why these are showing so much promise?
Yeah, this is so exciting for us. I know, in the talks I give, I say a revolution in cancer chemotherapy because it is still chemotherapy. One of the things that's happened because of the trials is sometimes people think it could replace hormone therapy, but actually being on pills and being able to not be tied to the infusion center, have IVs, is always going to be something we want to do first. If you have, as you have, hormone-sensitive disease, these can be just huge benefit in terms of staying on oral therapy for years and years. So we don't want to be jumping to IV therapy. But that said, we need IV therapy. We need a way of delivering chemotherapy. And we have jokingly referred to chemotherapy for decades as kills all. It's like you give the drug IV, it goes everywhere, right? And the idea is that it kills cells that are dividing more rapidly. The idea behind antibody drug conjugates is this smart bomb approach where the cell that you are targeting expresses a protein, and that's where the antibody that has linked to it a toxin will go. The cell knows to bring that antibody linked to a toxin inside the cell where the linker is digested and the toxin is released and kills that cell, we hope with less toxicity to the whole body. So they're very exciting drugs. And the first one we had was for HER2-positive breast cancer, and it didn't actually work for other subsets of breast cancer, trastuzumab emtansine. But that led to this new generation of antibody drug conjugates, which target HER2. The most successful one targets HER2, but also target other antibodies. The other approved drug targets TROP2. Sacituzumab govitecan, and the HER2 is trastuzumab deruxtecan. They have really big names.
Yes.
And so we abbreviate them, TDXD, SG, But because of the success of these drugs, there's a whole new group of these ADCs, some with the same antibody target, some with the same toxin, but some with brand new on both sides. So we're really excited about them. So why are they so cool and why are we so excited about them? One thing is that we thought that you needed to have a lot of the target. So if your antibody was against TROP2 or HER2, that the tumor had to have a lot of that target. But our studies now have shown that you don't need to have much of the target. And actually, the way we detect the target may not be important at all. Like you could have 1 in 1,000 cells that has the target and it would still work. That's very exciting because it would mean that these antibody drug conjugates could work overall for breast cancer, and it wouldn't need just to have that subset that expresses the target. The other thing we found is that although there are side effects from these drugs, that they seem to be fairly predictable for each ADC, and we can largely get around to those side effects. And then lastly, I think of course the most exciting aspect is that they're better than standard chemo. So the first two, T-DXd and SG, showed not only were they better than chemotherapy in shrinking the cancers, but the cancers stayed shrunk without growing for much longer, and patients live longer.
And I think that's the question, and the questions that keep coming through. We've got questions coming through our Q&A. It's a difficult question to answer, but people with metastatic breast cancer, we can treat it, but it remains incurable. And people want to know how much longer these drugs are giving them in their overall survival. And I know it's a very big question. But can you talk us through, when we're talking about what you're saying, the excitement around these antibody drug conjugates, how long are people getting on these drugs? Do we know yet? Is it too early to say? What do we know?
You know, it's a complicated question because it depends on how the studies were done. Which patients were included? Did they have hormone receptor positive, triple negative, HER2 positive disease? Were they treated after 1 line of chemotherapy, without any chemo, with 4 or 5 lines of chemotherapy? Because the farther out you go and the more treatment you've had, unfortunately, although the treatment still worked better than standard chemotherapy, the benefit narrows, but it's still better. So what we look at is something called hazard ratio. It's very complicated, but it's a relative benefit. So what percentage more do you benefit than getting the standard treatment? And those have all been quite, what I think are important for patients, so that you could live 30% longer, for example, or 20% longer. And what we do is we sometimes look at specific time periods. So at 6 months or 1 year, what percentage of patients are alive who got this new therapy versus patients who got the standard treatment? And you know, if the difference is 8 or 10% more people are alive, that's a big difference, I think, for patients. Now, you're balancing always the side effects, right? So some of my patients have gotten these ADCs we're so excited about and had a lot of side effects, even from T-DXd, you know, a lot of fatigue, nausea, things we really have to manage. And so understanding those side effects for the specific patients and managing them turns out to be really critical. You know, I have a few of my old ladies, I say, you know, the patients in their early 80s who are getting the T-DXd every 4 to 6 weeks because otherwise they're just exhausted, you know. The cancers are well controlled, and so you're giving it less frequently. It's like the palbociclib, where you might take, I have one patient who does, she's also 81, she's one of the patients who's been on for 11 years, but she stays on for her 3 weeks, and then she takes 10 to 14 days off. And that works well for her. It's like the dose, you know, I dose reduced once, not twice, but it's that we take that extra time off and she manages it. I think it's sort of working within how a patient is managing that makes the biggest difference. Yep. I had one patient, I was like, okay, this is your second line of chemotherapy. You know, she had very hormone sensitive disease, so been on for years, but she kept getting obstruction of her bowel from this lobular cancer, always really hard to treat. So I gave her the T-DXd and she was like, you're trying to kill me. Her bowel obstruction went away, but she was so exhausted, she couldn't get out of bed. And remember, this woman has been on treatment for like, you know, I don't know, 16 years, you know, so it's hard, right? And she's quite a bit older. So she, the bowel obstruction went away and she was like, I'm not taking this drug anymore because I'm gonna have to sell my business. She does an online education business. I just can't manage my life. But I know that my tumor has this estrogen receptor mutation. Of course, she'd been treated long before we had our drug that targets ESR1, the estrogen receptor mutation. a drug called elacestrant. And she said, I want to go on to elacestrant. I was like, well, it doesn't work well after chemotherapy, but, we work with our patients.
Yeah.
So I said, you want to do this drug? We'll give you the drug. Yeah. So she went on elacestrant. She went on elacestrant in December, and she's still on it. So and she is doing really well. So it shows you, you really have to, it can't be just what I learned from the studies. It has to be what you learn from the individual patient.
And when we talk about lines of treatment, so what does that mean to the viewer watching? Just talk us through when we talk about lines and sequencing, just the definition of what that means.
Yeah, it's a really interesting concept, and I have to say we're always talking about it, and people use different language. So for hormone receptor positive disease, we'll talk about lines of hormone therapy with or without a targeted agent. So for example, the first treatment you get when you're diagnosed with metastatic disease is your first line treatment. And then when the cancer is no longer controlled with that treatment, the next treatment uses second line and then third line, et cetera. Now, when you start chemotherapy, as clinicians, we recognize this is a different step. We call it first line chemotherapy. So then you go on to second line chemotherapy and third line. Some people will talk about all those lines mushed together, but it doesn't really make sense biologically in how patients do. So we really try and separate them. For a patient who has triple negative disease, every line is going to be chemotherapy with or without some kind of targeted agent, or an antibody drug conjugate. So then your lines are always limited, right? So the first line is going to be chemotherapy with something or not. And then you keep going along.
How many lines can people have?
Well, see, the reason why are lines important?
Yeah.
One is we're always thinking about clinical trials and the results of clinical trials, right? So you may not always have access to a clinical trial, but we say to patients, it's really important each time you're going to change a treatment, find out what's available to you. What clinical trials exist? Because remember, the drug companies, the pharmaceutical companies, they want their drug to get approved. They know the chances of being better than the standard of care is going to increase if the patient has had less treatment. Why is that? That's because under the pressure of treatment, the cancer acquires more resistance mechanisms. So the treatments don't work quite as well farther out. Some treatments do, but some, mostly they don't work quite as well. So we want patients to have access to these new agents we're excited about that aren't yet approved but are in trials. So that's why the line of therapy plays such a big role. How many lines of therapy can you get? And should you get, for example, one of my patients who's a very strong patient advocate internationally, when she first got diagnosed with metastatic disease, she's a physician, but she specialized in something else. She lived in a rural community, and the doctor there gave her 2 lines of chemotherapy for hormone receptor positive disease to bone. So we know now that is the wrong approach. Yeah. She didn't need the chemotherapy, and she didn't need it then either. So you're kind of panicked when you get metastatic disease. You're anxious, but you want to question what's there. There is rarely, with a few exceptions, an emergency where you have to make a decision by tomorrow or the next week. You have some time to pursue the right treatment for you so that you keep your options open. Yep. If you have very hormone-sensitive disease, you can get many lines of therapy. If you have less hormone-sensitive disease, we're talking about hormone receptor positive breast cancer, you may have less lines of therapy available to you. So patients will say, what can I do? And I say, well, the proof is in the pudding. The longer you stay on your first line treatment, the better the next one works. Yeah. So that's part, and we learned a lot from the CDK4/6 inhibitor trials. The second, when you got palbociclib with fulvestrant, they allowed people to get 1 line of chemotherapy before. About a third of the patients had 1 line of chemo. Nothing worked as well. So we learned that under chemo, you generate resistance to even the hormone therapy. So it's really made a big impact on what we want to do, think about, and teach, which is you want to use up your hormone therapies first with their targeted agents.
Yep. And to that question, I might throw to that question, Katie, if you can ask Hope, and you're representing the local voices and all of those people asking questions around clinical trials.
Yeah, so we hear a lot, I think, in the metastatic community about this almost a fear to get onto a clinical trial. issues finding clinical trials, but mostly that they won't be receiving the gold standard of care that they would be if they were on a standard treatment from their clinician. What would you have to say to people about the importance of clinical trials in their lines of treatment?
It's a great question, because we do want to use education and the reality of treatment to try and counter some of those fears. You know, it's interesting. People have looked at patients who participate in trials and those who don't. The patients who participate in trials tend to live longer. There's a lot of bias in those trials, right? Because, you know, who qualifies for a trial and et cetera. But I think what's most important is that trials come in a variety of shapes and sizes. So when we have a new drug that we're testing and it's never been given to people before, so-called phase 1 trial, first in human. That's a treatment that we generally only use when we don't have any more good treatments to offer. So breast cancer patients, because they have a lot of treatment options, are generally not well represented in those first in human trials. And we don't know the right dose, we don't know if the drug will work, but you know, there's a lot of promise, and all the drugs that work now came through those trials. So you could benefit a lot in specific situations. The next set of trials are called phase 1B. That's where you take a drug, you already know the right dose, and you know that it has some effectiveness, and you combine it with another great drug. So for example, you might have a new endocrine therapy you're really excited about. It already has shown a lot of effectiveness, but to combine it with a CDK4/6 inhibitor, you have to do that phase 1B trial. So those are great options because they're not randomized, you go on it, we have high hopes that it's gonna work well. And then phase 2, very similar, where you already know that the combination is safe, and you're expanding the population of patients who are getting that to look at effectiveness. And that's mostly a really safe bet for most patients. There are randomized phase 2 and phase 3 trials. Phase 3 trials are the trials that lead to drug approvals, and they always use the gold standard as the control. So if you're randomized on that trial, you know, I've had a lot of people, you know, disappointed with getting one arm or the other, but the gold standard is still the best we have. So that's the control arm. We don't randomize to placebos.
Yeah.
We
And
never
that's the
do that. It
misconception
is really
sometimes.
important. People are always saying, well, could I get a good treatment plus a placebo? Well, you could, but that's only in the situation where that is the standard of care, you know? And we're really always promoting crossover. Like, you know, if you do a trial, could you cross over and get that new cool drug? But, you know, the regulatory agencies don't like that so much. But sometimes there are alternatives as well. I think, you know, a clinical trial also brings with it some other benefits, which is that you get a concierge service. You know, your research coordinator schedules everything for you. They're there, they answer questions, you know, you are very closely monitored. And what's really important is you can always jump ship and go on to a different treatment.
Yeah, often our webcasts for people with metastatic breast cancer tell us that they've not heard that there's clinical trials available to them. And we do encourage people to go back to their training team, to their clinical team and their doctor to really inquire and ask about what's available to them. Do you find that where you're from that, you know, people are not sure or they're not aware of those things that are available to them?
I think that is universal.
Okay.
And I also think that there's a mistake that sometimes happens with the providers as well as the patients, which is they wait until there's no more good treatments. You've run out of treatments. I want to see if I qualify for a clinical trial. This is where phase 1 trials are. So if you really want drugs that have already shown some effectiveness, you got to do it earlier. For example, our patients who've had first-line endocrine therapy with the CDK4/6 inhibitor, we're looking at novel targeted agents and we're looking at novel endocrine therapies, often in combination. So these are great options for our patients for treatment. And I think that, you know, how do you find them? You know, your doctor says, I don't have time, I have 15 minutes to see you, and your other providers, we use a lot of allied health professionals, nurse practitioners, et cetera, in the United States. You know, people just may not be aware of the right trial. So our patients will actually do research often and send me, you know, the NCI.gov listing. And actually around the world, most trials are registered through the National Cancer Institute of the United States. So you can find those. Organizations like this one actually often can help you so you can go to advocates and say, where can I go? And what you do is you get a second opinion at a big institution. And I think that, in Australia, telemedicine also works for these second opinions, and it makes a really big difference because you can find out if what you're doing is on track and also what the next step might be before you're there and you need your appointment tomorrow.
Yep.
It makes a big difference.
So we're going to jump into immunotherapies. What can you tell us about immunotherapy? We know that immunotherapy has been quite effective in melanoma and lung. Can you talk to us about breast cancer, metastatic breast cancer, and also triple negative? We've had a couple of questions about triple negative as well, breast cancer.
Immunotherapy, we thought, when immunotherapy came about for the other cancers, we were kind of like, right, breast cancer is not an immune responsive cancer because the slow-growing hormone receptor positive, hormone responsive cancers have not been very responsive to immune manipulations, and they don't have the immune markers so much. But of course, understanding triple negative disease, HER2 positive disease, the more aggressive forms of hormone receptor positive breast cancer has led us to a new understanding of immunotherapy, where we saw first that these drugs called checkpoint inhibitors that block the tumor's ability to suppress your immune response against the cancer.
Right.
That these checkpoint inhibitors worked in triple negative breast cancer in the metastatic setting as single agents. But the response rates were pretty low in the first, like if you gave it as the first line treatment, the response rates were around 20 something, low 20%. Not as good as we'd like. And if you gave it after the first line treatment, where the cancer is suppressing your immune response very effectively, reducing the immune markers, the response rates were more like 5 or 6%. So really nothing that we want to give to our patients. So then we understood from the laboratory that combining immunotherapy with chemotherapy really enhanced the ability of immunotherapy to work because you're stimulating the patient, the host, immune response. You make more of your immune cells target the tumor, and you can actually increase the number of immune markers on the cancer cell. So that we saw in the first line chemotherapy setting in triple negative breast cancer, we could add an immunotherapy, pembrolizumab, to chemotherapy in patients who have an immune marker called PD-L1 and improve the response, the duration of response, and the survival of patients with this really difficult to treat subset of breast cancer. But we were sort of disappointed that with these positive results came the understanding that only about, in that trial, 38% of patients' tumors express that immune marker.
Yep.
So now the focus has really been on combining different immunotherapies and combining immunotherapy with antibody drug conjugates to try and really enhance the effectiveness of immunotherapy for metastatic breast cancer. I actually published the main report on using immunotherapy in hormone receptor positive metastatic breast cancer. We needed the tumors to be PD-L1 positive, and it was a tiny number of tumors, and the response rate was about 12%. So it wasn't pursued as that single agent, and they don't play well in the sandbox with CDK4/6 inhibitors. They have a lot of combined toxicity side effects. But what we found was that patients who did respond, their tumors responded, they had very long disease control. So there's a lot of interest in testing immunotherapy for triple negative breast cancer in the early stage setting and then hormone receptor positive disease. And in our neoadjuvant I-SPY trial in the United States, we've actually shown that pembrolizumab was very effective in shrinking the cancers in the treatment before surgery for early stage triple negative breast cancer. So now what we've learned is if you give chemotherapy with pembrolizumab before surgery for patients who have tumors that are greater than 2 centimeters or have positive involvement of the nodes under their arm, that you can improve the number of patients who have no invasive cancer at the time of surgery in their breast or nodes. You can improve the risk of recurrence locally and at distant sites. And as we'll hear in September at our international meetings, you can improve survival. So that's been very exciting for hormone receptor positive aggressive disease, so fast growing disease. we've now seen in 2 trials that you can improve the number of patients who have no cancer, no invasive cancer at the time of surgery by combining pembrolizumab with chemotherapy. We're waiting to see if this translates into less recurrence after surgery. So it's been a very exciting time to see this tremendous improvement in our hardest to treat subset of breast cancer. So now we're looking at immunotherapy combined with antibody drug conjugates. We're looking at immunotherapy combined with ADCs, the antibody drug conjugates, as a way to rescue cancers that don't shrink well in the metastatic setting in a subset of patients with HER2-positive breast cancer, and in combination with other immunotherapies. So it's a very exciting time.
And if you put that into the perspective of your career, is this the fastest we're seeing, growth in this space? Like if you think about your career and your time, is this the fastest? It feels like it's exciting.
A lot of momentum.
Yeah, a lot of momentum.
I would say, CDK4/6 inhibitors, we made a lot of progress very rapidly. We were all ready to go to the FDA and they gave accelerated approval to palbociclib. We didn't have to go, actually. So, and immunotherapy, I think we've also seen really a rapid translation of treatment in the metastatic setting to early stage disease. I think what's been really exciting is that these trials in the early stage setting increase the number of patients. We're thinking like we want to enroll trials that have the smallest number of patients to get the answer we want. But by doing trials before surgery, with more patients, you could see with a single trial, no cancer at the time of surgery, less recurrence, and improved survival, all in one trial. And that's really exciting, I think. Much harder to do with endocrine therapy where you don't see that kind of shrinkage. But we've also seen a rapid evolution of therapies that are highly effective for HER2-positive breast cancer as well. So that's been also really exciting.
Katie, I just might throw to you to ask around your experience of fear of progression and resistance, if you want to touch on that for us.
Yes, I'm so glad you asked, Vicky. For me personally, I know I almost live every 3 months, scan to scan, and I know that a lot of us feel the same. Is my treatment still working? Am I going to stay on the same line of treatment? It's always in the back of your mind. We are now hearing about a new way of testing. Now it's ctDNA or circulating DNA. It's not yet here in Australia, but you might be able to share your experience. It's very exciting. It sounds like a measurement of how the disease is progressing through real-time monitoring in the body. Can you tell us a little bit more about that and what you're seeing through those results?
Yeah, this is also a huge improvement in our technology, but it's still a work in progress. So ctDNA, or circulating tumor DNA, sometimes referred to as cell-free DNA, but they're different. One is tumor, for our laboratory colleagues, and one is cell-free DNA. ctDNA is a component of cell-free DNA. But there's a lot of different technologies that are looking at these, and where we've seen the biggest use and the approved regulatory approval has occurred is looking at mutations that are driving cancer growth in metastatic breast cancer. So rather than using it as a way to assess the effectiveness of treatment, we've used it to look for, say, a PI3 kinase mutation or an estrogen receptor mutation called ESR1. And now those are tied to the regulatory approval of agents, so you can use these tests to treat patients with targeted therapies. And one thing, not in Australia, but has been interesting is looking at what we call somatic mutations in HER2 and even in BRCA1 and 2, the BRCA1 and 2, where it's not something that's in all the tumors that all the cells that you inherited, like the BRCA mutations we inherit, but it's acquired mutation. And the same true of HER2. It's not that gene amplification that we look at when we test the tumor, but it's a mutation. And those patients can respond to targeted agents against those somatic mutations. So it's been, I think, really important. And we've looked at the evolution of mutations. So for example, if you test early, you don't see, for example, the estrogen receptor mutation. It's a mutation that occurs later under the pressure of treatment. So that's where the clinical value is in all of our guidelines, regulatory approval. So the second question is, could you look, we used to look at circulating tumor cells, but circulating tumor DNA, could you look at the decrease and increase as a way to monitor response to treatment? Sure. Right now, my feeling about that is it's way too sensitive. You might have, cells that are going up and down a little bit. You don't want to be switching treatment until the treatment really isn't working. Sure. So I wouldn't use it for that purpose now. I really would strongly discourage it. For early stage breast cancer, like when you were first diagnosed, there's a huge amount of interest in trying to figure out whether or not we could use ctDNA to understand the effectiveness of the treatment you're getting. So I mentioned that abemaciclib, one of the CDK4/6 inhibitors, is approved to treat high-risk early-stage hormone receptor-positive breast cancer. Shireen Loy in Melbourne actually presented at our recent international meeting data that looked at a subset of patients who were on that trial, and if they had the ctDNA when they went into the trial and it didn't go away, they had a much higher risk of recurrence. If they went in with no ctDNA for the tumor and it came back, they had a higher risk of recurrence. That ctDNA is called tumor-informed. The one in the metastatic setting doesn't matter what your original tumor had. This, they take the original tumor and they look for what that tumor had. And that technology is changing a lot. Should you do the testing now? We don't know how to fix it if the ctDNA is positive. So I discourage testing, because people can do it in the US if they're totally attached to it. Again, this is an issue where patients need some control over an uncontrollable situation. So somebody says to me, I understand the limitations, I really want to do this testing, I'll do the testing. But it's testing over a long time. Sure. There are a lot of trials looking at somebody's ctDNA turns positive, multiple testing. Should we change the hormone therapy, add a targeted agent, do something different? Those trials are going to be really important for us to understand if we could prevent this pre-metastatic disease from becoming metastatic disease. And we don't know the answer to that now.
And while we are talking about testing, I know that this is a discussion that's happening in our lived experience group at the moment. Some of us are getting CT scans, PET scans, bone scans. Is it a one-size-fits-all approach when it comes to that? Is it up to the clinician to send you off for your scans, or is it dependent on subtype? A lot of us would like to know why we're all going for different scans.
That's a tough question. PET scans come in two varieties. One is PET with a fused CT, and the CT doesn't give you very good images of the tumor. So you're measuring the tumor by how much the tumor picks up radio-labeled sugar. There's even an estrogen scan, it just doesn't work in the liver. But, that's a problem because you could overinterpret what the size is and change therapy too early, which we don't want to do. On the other hand, it tells you a little bit about the metabolic activity of the cancer, right? So diagnostic CT scans give you a much better image. You can measure the tumor, you can look at things, you can see what that changes on a millimeter level. And then bone scans, nuclear medicine we call unclear medicine. Bone scans can be useful sometimes if somebody's having new bone pain and we're trying to look at that. PET will also give you uptake in bone. So I think that it has to do with what you're looking at for an individual patient. So, what helps you the most? What I do is, if I'm looking at bone, somebody has bone-only disease in the bones, I'll do CT scans, 3 to 4 months, whatever it is. The longer somebody's cancer has been quiet, the farther out we go between scans, but never after 6 months. I never go farther than that. It helps us look for lung nodules and liver nodules, soft tissue masses, lymph nodes, et cetera. For bone disease, sometimes the PET with a fused CT is best because it tells you about the activity of the bone. It doesn't matter if there's activity in the bone, but you want to find new sites or problems that occur before somebody has more symptoms. So I think that, there are pluses and minuses to all of the scans, and we really have to balance it against the individual patient's disease. If you have very slow-growing bone-only disease, it may not pick up anything in a bone scan or a PET scan. So then a CT is better. So, you know, an MRI of your hip, for example, will tell us a difference. So we really use symptoms and the disease biology to guide us.
Yeah. Can I ask, we've got a couple more minutes, and I did want to talk to you about what are you really interested in seeing coming out of the US and globally? Are we starting to see other new treatments or clinical trials that you're getting really excited about? And there was one other question coming through around brain mets. Are we seeing any clinical trials in that space?
Yes, so I'll do the brain mets first. I think that we have seen that some of these antibody drug conjugates and some oral small molecules, so pills you can take, have effectiveness against brain metastases and make them shrink, which is so fabulous for us to see because chemo works really variably. Sometimes it helps, sometimes it doesn't, and it can be really hard to treat. So the oral drug, tucatinib, is only for HER2-positive breast cancer, but the antibody drug conjugate, TDXD, clearly shrinks brain mets for HER2-positive disease and even has had some effectiveness against tumor that's in the lining of the brain, which is very hard to treat. So we're hopeful that treatment with TDXD in the right setting might help to prevent or delay brain metastases. And it's not just confined to patients who have HER2-positive disease. We've seen the effect in patients who have HER2, just a little expression we call HER2 low. So I think that there are some exciting advances in treating patients who have brain metastases that we hope will translate into prevention in the future, which our standard chemotherapy has not been so great at. And then, you know, what are we most excited about? I think, you know, we like taking the drugs that work into the early stage settings so that we don't have recurrent cancer. I mean, that's what we would have wished in your situation. You know, we want to try and understand how to treat these cancers optimally. And I think that the exciting things for me are really trying to move treatment into the neoadjuvant setting so that in the future we could use response to treatment before surgery to individualize the treatment. So if you have a fabulous response to whatever that treatment is, maybe you need less treatment. You don't need the whole thing. And you could sort of tailor the treatment to be less. But if you have the kind of cancer that's not shrinking well, then you need to escalate treatment earlier to try and reduce the chance of recurrence. And for some cancers, where the recurrence occurs very quickly after you finish treatment, those patients probably have some area of metastatic disease that we aren't seeing very early. Will it help us to know that? Maybe. And so we might be able to in the future use ctDNA to help us guide that way. So some of the targeted new imaging areas. So, and of course, optimizing the sequencing of treatment in the metastatic setting is a key area as well. These new endocrine therapies and new targeted agents, I think I'm really hopeful are going to help us a lot to try and help patients to live as long as possible with the least toxicity and the least impact on quality of life.
So it's all about personalization, really.
Absolutely.
Yeah.
And just, if you can just touch on as closing remarks, I think you'd mentioned before, we have a number of key leading researchers in this country that I know you have worked with. Just, can you share with our audience how well placed Australia is within clinical trials and ensuring that these new and emerging treatments are hitting our shores here in Australia for providing hope for people with metastatic breast cancer?
In Australia, of course, there are international leaders in breast cancer research. And of course, I mentioned Shereen Lloyd, but there are many others who are really pushing the envelope further. And interestingly, my colleagues in Australia are not just focusing on clinical research and clinical treatment, but also what's behind that. So the laboratory studies that are really going to help us understand what drives tumor growth, what we're looking for in the sort of change in the tumor environment or the markers in the tumor environment. And a number of researchers in Australia have made tremendous advances in this area now. I think Australia really participates actively in all of our important international clinical trials and has reported those trials. For example, Prue Francis reported the data on the biggest trials that changed endocrine therapy for young women with breast cancer. That's just one example. And then there are many others. And it's not just the treatment, but also in the surgery area. There are tremendous researchers that have done a lot of work, and there's a lot of collaborations going on with Australia. I think the major downside is just that it takes a long time to get the drugs to market,
Yes.
mainly because of the fact that everybody in Australia has healthcare, which is a great thing. So that's obviously something to work on more in the future. But in terms of accessibility to clinical trials and the work that's going on, it's really the top.
Yeah, fantastic. Any last parting words from you, Katie, as we say goodbye?
Oh, I think I'm going to be going back and rewatching this webinar when I get home. It's been such a pleasure to have you here and have you impart your wisdom on our community. I've very much been honoured to be here as a voice of our lived experience community living with metastatic breast cancer. And I just hope that everything that we've spoken about today can be taken into our system and that we see it in the future coming down the pipeline to Australia.
I feel very confident that it will. It's been a pleasure having you here. I appreciate you being here and being part of this conversation.
Yeah, thank you so much. Please join me in thanking Hope and Katie for joining us. Today's session can sometimes in these sessions can be emotionally triggering for you, and we're really mindful that you reach out to our helpline at Breast Cancer Network Australia at 1800 500 258, or if you need to call, we're open Monday to Friday. This webcast will also be on demand and be available in approximately a week's time, so please look out for that. We also have a survey. If we can ask you to complete that, that's really helpful to help inform our programs moving forward. So please share your feedback with us. We hope that this has been a really informative webcast, and we really thank you for joining us.